Hello, and welcome to the March 2022 edition of Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid. My name is Claudio Varga, and I'll be your host for today's program. The Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid, is a monthly virtual meeting open to anyone and everyone free of charge, where we share and discuss all things related to urgent care, both in California and nationally. The California Urgent Care Association is a state chapter of the National Urgent Care Association. If you are a member of UCA and located in California, then you're already a member of CALUCA. We urge and invite you to become more involved with us. There's a lot going on, and we'd welcome your participation. For more information about CALUCA, please visit our website at www.caluca.org. We welcome your feedback and suggestions for future episodes of Urgent Care Town Hall and invite you to be a presenter yourself. Just email us at info@caluca.org. Quick reminder that the annual Urgent Care Association Conference is fast approaching and will take place in Las Vegas at the amazing Caesars Palace Hotel from April 30th to May 4th. CALUCA will host a lunchtime meet and greet, and we'd love to see you all there in person, in the flesh. The final details of this event will be forthcoming very soon. Keep an eye on your inbox for more details. We've got a terrific program today with a distinguished guest speaking on a fascinating topic. But first, on behalf of the Board of Directors and our membership, we'd like to thank and welcome Cepheid for their sponsorship of not just today's town hall, but the entire Urgent Care Town Hall schedule for the rest of 2022. Over a decade ago, Cepheid set the standard for innovation in automated molecular diagnostics, and they've never looked back. Today, Cepheid can boast of having the largest installed base of any molecular platform, and is constantly innovating and evolving its capabilities to keep pace with today's shifting healthcare landscape. The Gene Expert system has been heralded as game-changing by healthcare leaders across the globe, enabling institutions of any size, from small medical clinics to urgent care clinics to high-volume reference laboratories and hospitals, to access the speed and accuracy of molecular diagnostics. Cepheid's growing expert test menu spans multiple clinical applications, including healthcare-associated infections, sexual health, critical infectious disease, virology, and oncology. Of particular value during the COVID-19 pandemic has been their PCR Plus system, which delivers speed, accuracy, and flexibility. Please visit cepheid.com today to learn more. Our special guest today is here to talk about an epidemic, but not the one you're thinking. For 2 years now, pretty much all we've talked about is the COVID epidemic and pandemic, and rightfully so. It's been a global tragedy. No corner of this earth has been untouched by COVID. But now, fortunately, COVID seems to be retreating, and it appears that we are winning the fight. What we're going to discuss today is a different epidemic, a nearly silent and insidious destroyer of lives that casts its dark shadow of pain, despair, and all too frequently death across every corner of this country, and which requires no less the effort to eradicate that COVID does. Dr. Casey Grover is a board-certified emergency medicine physician practicing at Community Hospital of Monterey Peninsula. Dr. Grover also specializes in addiction medicine and is the physician champion for the Monterey County Prescribe Safe Initiative. He is also the host and publisher of the Addiction in Emergency Medicine and Acute Care podcast. Dr. Grover is joined today by Dr. Jen Hastings, Ms. Rita Hewitt. Both are with the County of Santa Cruz. Welcome to the show. We really appreciate you being with us here today. Dr. Grover, please tell us what the other epidemic we need to be talking about. What is the other epidemic we need to be talking about now? And what is it that makes you so passionate about fighting it?
All right. Well, I certainly wanted to say thank you for including all three of us. I think I got a little bit of over representation on my contributions here. Rita and Jen and I worked quite a bit together on this presentation, so I want to say it's a collaborative effort. Rita, did you want to introduce yourself as we get started? I know Dr. Hastings is going to join us in just a little bit.
Sure, thank you. And thank you for having us today. We really appreciate it. My name is Rita Hewitt, and I am the program manager of SafeRx Santa Cruz County, and that's our local opioid, now kind of all substance safety coalition, and it's a sister coalition to Casey's Prescribe Safe Monterey. And yeah, I will be here to share a few things about locally what we're seeing around this topic. Thank you for having me.
So we are going to be talking today about illicit fentanyl, the history of the epidemic, the overdoses, trends of those overdoses, and what we as a collective healthcare community can do about it. And we're going to look at basically four topics: a history of how we got here. People often wonder, why are people putting fentanyl in the street drugs? We're going to look at some trends nationally in California. Rita and I will present our experiences on the Central Coast with the trends. And then Dr. Hastings, and I apologize, I will often reference Jen as my colleague, so I will refer to Jen as Jen. And then Jen, Rita, and I will also present kind of what we think are best practices as to how we can fight back. So first question, and I love history. I can hear my daughter rolling her eyes from school because she always gets annoyed when I like to talk about the history. But how did we get here? And if anyone wants a great book to kind of lay out the first phases of the opiate crisis in America, this is it, Dreamland by Sam Quinones. And Sam really opens the book with a time when America really wasn't using really any opioid at all. The average American in the 1950s used less than one opioid tablet a year. And what ended up happening is physicians and the medical community started really trying to be more aggressive with pain treatment in the 80s and 90s. And it started with a couple institutions creating comprehensive pain programs. And I like to call these pain camp. You would see a nutritionist, a psychologist. You might do some physical therapy, and then they might add in some medications. And unfortunately, as I think we all now know because of the news about Purdue Pharma, we were getting education as physicians that we really needed to be more aggressive with opioids. And at a certain point, these comprehensive pain approaches really weren't being reimbursed by insurance. And so it was this kind of progression where we were focusing, rather than a holistic approach to pain, let's focus on opioids. Pharmaceutical companies were teaching physicians that opioids were not addictive. All of a sudden, pain was a standard measurement, a vital sign. Joint Commission was measuring, time to intravenous opioids for long bone fractures. And it was all really great, except we really missed the mark on what opioids were doing. And then right around this same time, there were some political changes where we'll talk about, where heroin began coming into the United States. And we're going to look here initially. This was an original copy of an OxyContin ad that says your doctor might prescribe an opioid, less than 1% of patients become addicted. And what's important about opioids is that with regular opioid use, 100% of patients will develop dependence. My dad, for example, was a cancer patient. He was on hydrocodone and methadone. He took opioids every day when he was dying of cancer. He was definitely dependent, but never addicted. He would have gone into withdrawal had he stopped his opioids. So opioid dependence wasn't really mentioned here. And then additionally, people can develop addiction. What is, I think the best term now is an opiate use disorder. And it's estimated that as many as 20% of people who are regularly exposed to opioids may develop an opiate use disorder. And if you're wondering where this 1% came from, it was this little kind of side note in the medical literature. It's a letter to the editor in the New England Journal of Medicine. And here's the entire content of that letter. Sorry, I keep misspeaking. Letter to the editor, 9 lines, and it's been cited more than 900 times in the medical literature. So really, from the very beginning, as we introduced more opiates into our practice as physicians and healthcare providers, we were already kind of going down the wrong path. This is a great book by an author named John Temple that just talks really about kind of the worst of the opiate epidemic in America. There was a group of now felons who were running pain clinics in Florida and really taking advantage of the phenomena of dependence and addiction to make money. They were running pill mills, and at one point, Florida was dispensing 9 times more OxyContin than the rest of the country combined. And unfortunately, those pills from doctors, as we all know, bled into the street. This is a website called streetrx.com where you can actually price check, is the drug you're buying on the street, are you getting a good deal? And just kind of, it speaks to the pervasiveness of how much opiates were ending up on the street. And this brings us to, we don't have one opiate epidemic, we actually have 3. The first was us as healthcare providers overprescribing. And what I was taught in my residency is if someone has a problem with opioids, you cut them off. And that was really the wrong thing because it misses this phenomenon of dependence. People go into withdrawal. And unfortunately, when doctors were cutting them off, people really had nowhere to go but to the street. And heroin was that next wave of the opiate epidemic. Uh, a bit of history, heroin actually came to the market originally by Bayer Pharmaceuticals as a cough relief. And I love this. It was originally marketed as non-addictive, just the way OxyContin was. History repeats itself. Now, what's interesting about heroin is heroin has to be grown. This is a shot of a field of opium poppy. So you can imagine if you're in the illicit drug trade, you have to grow the poppy, you have to maintain the poppy, you have to process the poppy, you then have to get it to where people are buying the drugs, and that involves smuggling, drug mules, and a lot of potential for the risk of crime. And what we've certainly seen, particularly at the US-Mexico border, is the rise of these multinational crime organizations. This is a photo of a raid on a drug cartel nest, and you can see those are the Mexican Marines that have apprehended these people. And additionally, there's been this crackdown of law enforcement really trying to crack down on the drug trade, and specifically, they'll go into these opium poppy fields and cut down the poppy to try to destroy them. And so if you're in the illicit drug market, it's a really inefficient way to get your product to the street drug market. And this is where we see a pivot to the third wave of the opiate crisis, which is a pivot from naturally produced opioids on the street market like heroin to synthetics like fentanyl. And what's really interesting is fentanyl is legal. Like, I worked an ER shift last night. I used fentanyl for one of my patients that had a kidney stone. And so it raised this question of, gosh, well, if fentanyl is so potent and it's synthetic, maybe there's a better way. If we in the drug smuggling or drug trafficking industry, maybe we can be smarter and find an easier way to get drugs into the street market. And this comes down to a phenomenon called the iron law of prohibition, which is if you make a drug or substance illegal, people will come up with a way to make the substance or drug more potent so it's easier to smuggle. And this was seen very specifically during prohibition of alcohol in the United States. We as Americans tended to drink beer and wine. Alcohol was made illegal, and people shifted to whiskey and moonshine, which was easier to smuggle because it was a lot more potent. Once prohibition was repealed, most Americans tended to come back to wine and beer. And this is really just kind of almost narconomics, if you will, the economics of the illegal drug trade. Let's compare fentanyl, which is ultra potent, compared to heroin. A brick of heroin is physically large. It has to be grown. It has to be smuggled. So fentanyl, it turns out, it's so potent, it makes it kind of the next logical step for the illicit drug market to want to use. The therapeutic dose of fentanyl is, let's say, for example, 100 micrograms. The fatal dose, for your reference, might be 2 milligrams. And a packet of sugar contains 4 grams of sugar. So if you take the amount of sugar that's in a sugar packet and you take that amount of fentanyl, 4 grams, doing the math, that's 40,000 therapeutic doses of fentanyl and 2,000 fatal doses of fentanyl. Turns out the US Postal Service allows you to mail up to 112 grams in a standard letter. So as police were cracking down on the heroin trade and it was getting more violent at the border, all of a sudden this web-based, I'm going to buy fentanyl online, which we'll talk about in just a sec, and ship it through the mail becomes kind of the next easy option in the illicit drug trade. And that goes back to the iron law of prohibition. Excuse me. So, and if you're wondering where buying drugs online came from, it started with a guy named Ross Ulbricht, and he created a drug market called the Silk Road. And if anyone's interested, there's a great book on this called American Kingpin. And he really created an anonymous eBay for drug sales. And this is actually a screenshot of the Silk Road. And at this same time, we saw the rise of Bitcoin and other cryptocurrencies that allowed people to make anonymous purchases. And so I literally, like this week, Googled buy fentanyl online. And this is a screenshot of what I found. you can buy fentanyl online so easily. And if you're wondering, how is this possible? Fentanyl is legal. So chemical companies are producing it. Fentanyl, furthermore, is so potent that it can be sent through the mail. And at the port of Vancouver, the port of Los Angeles, the port of New York, our mail companies just aren't able to screen every letter for a little tiny packet of fentanyl. And if you, as somebody who is trying to get into the illicit drug market, buys 10 orders of fentanyl and you're only ordering a sugar packet in each order, even if 8 of them get seized, you still can make 80,000 doses of illicit fentanyl product on the streets. And unfortunately, it's even worse because fentanyl is fentanyl is made synthetically. So the molecule only really needs to be modified very slightly to create the next and even more potent and therefore more easy to smuggle variant or analog. And so just for height here, these are 2-inch vials. On the left is the fatal dose of heroin. In the middle is the fatal dose of fentanyl. And on the far right is a fatal dose of carfentanil. And it's actually estimated that in Canada, as many as 20% of Canadians that are using fentanyl are probably actually getting carfentanil. And this is from the CDC in 2018. They detected 26 different fentanyl analogs in America's street drug supply. And we in Monterey County, we actually just detected a new analog as recently as 2 weeks ago. We detected acrylfentanyl. To the east in San Benito County, they've detected parafluorofentanyl. Police have sent me photos of, alfentanyl. It's just this unbelievable market, and no one really knows kind of what's being put into the street drug supply because, unfortunately, it's so easy to make these molecules, and some of them, as you'll see here, are being bought and sold as research chemicals, and they're not specifically regulated. This was another Google search. I was able to find a website that sells furanil fentanyl. I don't even know what that is as a physician, really. And guess what? You can buy it on social media. They're allowing you to make the purchase on WhatsApp. Really, this has just been just kind of an unbelievable evolution of a completely unregulated illicit market of ultra potent and ultra dangerous opioids that's getting into our drug supply. And there are so many articles of buy fentanyl online. So many magazines have covered. It's easy. You can do it at home if you're in that market. And it's so scary because, it used to be that we thought of people would only get to heroin if they've been using other pills or, excuse me, they've had an opioid use disorder for several years. We had a high schooler die in my county this week. And sometimes these kids, it's their very first time trying a pill on the street. And it turns out it might be furanil fentanyl at who knows what dose. And it's turning out to be fatal. So for my colleague up in Oakland, we are in the worst case scenario. We as doctors overprescribed opioids. We as a healthcare community didn't think to provide infrastructure as far as drug treatment, tapering protocols, access to methadone or buprenorphine to get people off of those opioids. We just told them, we're going to cut you off. People turned to the illicit market. And through a complex evolution in the illicit drug trade, we are now seeing fentanyl and fentanyl analogs arriving in our community at unprecedented rates. And as you'll see later, in unprecedented volumes. So I'm going to take a deep breath and I'm going to stop ranting. This gets me all riled up because I took care of a patient last night who was living this, who was on illicit fentanyl, and I was trying to help her get off of them. So what has this done to America? Well, it turns out it's killing Americans more than it ever has or than any other drug ever has. From the Center for Disease Control, we are seeing over 100,000 people dying from drug overdoses annually. And it turns out it's really all synthetic opioids, which means fentanyl and fentanyl analogs. This is some data from the CDC, and you're seeing that synthetic opioids, these are deaths plotted over time from synthetic opioids. It goes from 5,000 to 65,000 in about 6 years. California has an overdose surveillance dashboard. You can find it on Google. And we're seeing this in California too. These are fentanyl specific deaths. Again, from 2015 to 2021, about a 12-fold increase. So just really a very scary circumstance for us to be in. And we're also seeing it like we are in my community, getting into our schools, teenagers, high schools. And from just recently, about 2 weeks ago, I saw a news story that we're seeing overdoses happening in middle schoolers. So with that outstandingly optimistic preface, I'll turn it over to Rita here to talk about her experience in Santa Cruz County. And Rita, just let me know when to advance the slides.
Perfect. Thank you, Casey. So yeah, I just want to share a little bit about the Central Coast experience, and just there's a little map on the side just to orient you all with who we're referencing here. So I represent Santa Cruz County. Casey's with Monterey, and then we have another partner, Casey and Reb, our main partners from Monterey. We have another partner, Veronica and San Benito. And so recently, SafeRx and Prescribe Safe and Monterey and San Benito's coalition kind of joined forces in a program called the California Overdose Prevention Network, COPN. So we can have more of a regional response. And through our work, we've developed this kind of data dashboard through Infogram. And it's really beautiful, I think, in depicting each county, the trends over time and things like that. So you can see, there's just a couple slides on this, but you can see where Monterey, so California's the orange, and then Santa Cruz is that light blue, and then San Benito, thank you. I know, I got all my glasses on. San Benito is the green, and the dark blue is Monterey. So that those themes are the same colors throughout this presentation. So the first one you can look at is just kind of any opioid related deaths, and you can see that we've all had kind of these crazy ups and downs throughout the last decade, and then you start to see more kind of increases and somewhat of a plateau in certain counties for opioids. And then we can go to the next slide. I think this one is of note that essentially all counties saw an increase in every substance. These are fatal overdoses for benzodiazepines, fentanyl, cocaine, psychostimulants. The one that we haven't seen as much of an increase is benzodiazepines, that you can see is tapering off a little more, although we've just recently had 2 deaths of youth who thought they were using benzodiazepines, but they were tainted with fentanyl. So that's another issue, because the benzodiazepine was fentanyl really, and it wasn't a benzodiazepine overdose, but that is what the patient was thinking that they were taking. So you can see that, you know, right when the pandemic started, we noticed a big shift and uptick, kind of as we expected, sadly, with the lockdowns and things like that. So we all are experiencing increases in fatal overdoses. Go to the next slide. Thank you. Then this one that you can see, we're still kind of fleshing the details out on this, but you can see in this one, we're trying to track our Naloxone Administration. And as you can see over the years, it kind of has increased slightly, that we're being able to get those out. And so that's great. And one of the indicators is through our Harm Reduction Coalition, which I think is a great partnership, and urge folks on the call today to try and engage their community and see what kind of harm reduction support they have, because I think that is really integral to this work, and we'll mention a little bit later. But we have a great partnership in our community, and I think that's a valuable resource. And we also like to look at kind of the demographic breakdowns of who's receiving Narcan, you know, so age, gender. We have a really thorough county coroner who assesses marital status, housing status, job status. So we're able to really drill down the details of what populations we're seeing most affected by fatal overdoses and non-fatal overdoses, so we can, you know, target those populations and provide the support needed. And next slide. Thank you. So just more, so that's kind of just a high level overview of what our region is seeing. And in Santa Cruz specifically, you can see right at 2020, we just saw a significant jump in fentanyl, and we knew it was coming, and it came with a vengeance. We've had sadly quite a bit of youth fatalities in the past 2 years from fentanyl related overdoses. So something that we're kind of struggling with right now is we're seeing really two populations that are using fentanyl. We're seeing one of the kind of people who've had substance use disorder for some time and are really, savvy and understand the fentanyl test strips. And so sometimes are actually seeking out fentanyl. So they know how to test dose and all that. But then we are also seeing another population of youth and young adults who are really just trying to relax or have a good time on the weekend and take a pill from a friend or however they get it. And, it's a lethal dose. So we're struggling with that kind of messaging because it's very different populations, but they're equally as important. So that's where our community is really at addressing fentanyl right now as we see it surging our community. Next slide. Yeah, and just some really kind of grim statistics. Between January 2020 and September 21, we had 4 teens and 10 people that were in their 20s die. And as it states, most were in private homes spread throughout the county. And hearing some of these cases are really difficult, preventable situations. And we'll discuss kind of Narcan later on, but that resource would have, saved lives if we got that into the hands of more folks. And locally, we're also seeing that the fatal overdoses from synthetic opioids, but essentially it's really all fentanyl related, have quadrupled from 5 deaths in 2019 to 19 in 2020. And unfortunately, it seems like we were on track or surpassed that last year. We're still reviewing that data. So it's a really critical issue that we need to address, local and regional and statewide. Next slide. And then this one is just depicting us compared to the state. So as you can see, sadly, as I last mentioned, we need to address this really at the state level too, even more so, is that you can see how hard our numbers were, and we're kind of on a downward trend, whereas the state is just continuing to skyrocket. And I was just reading an article about San Francisco had more overdose deaths than COVID related over the last 2 years. So there's certain communities that are being hit so hard. And I think it's really important for us to, as COVID is doing whatever COVID's doing, new variant, calming down, I don't know, it's going to change every day. But essentially, this is such an important issue that we can't neglect it. We have 2 pandemics simultaneously happening in our country. And rightfully so, I feel like COVID was being addressed, but we really need to keep our eye on the ball with this because we are still losing lots of people and it's preventable. And so I think the next slide is passing it back to you, Casey, for Monterey. Thank you.
Yeah, and I will start by saying that we in Monterey County are totally jealous of the Santa Cruz data because you guys have way better data than we do. But looking again at the California opioid surveillance dashboard, we've had exactly the same trends in Monterey County. We've been extraordinarily aggressive in trying to get Narcan out and, trying to expand our access to buprenorphine, which we'll talk about in just a little bit. One colleague and myself, we work at the local syringe exchange, with a low barrier buprenorphine clinic. And we've had a little bit of a downtrend in Monterey County. I'm grateful to see from our peak in early in the pandemic, but the same trend overall. You can see that steep increase 2019 to 2020 when fentanyl was really just kind of coming into our community with a vengeance. I have to give credit where credit is due. My colleague, Dr. Reb Close, she is my counterpart, or my colleague and counterpart down here in our work in Monterey County, has been doing work with what's called the OD map, which is a software that tracks overdoses. And this is a screenshot of Monterey County's overdoses since October of 2019. So you can see the red diamonds are fatal, and then the circles are non-fatal. But we've had at our hospital on the coast in Monterey, and then also as far as fatal county data, we've had 1,407 overdoses since October of 2019, and that's only partial data, unfortunately. I think the other thing that's really scary here is that because fentanyl is synthetic, there's no limit on what can be produced. So this is from January of 2022. Police in my county sees 65,000 fentanyl pills. I mean, the supply is just obscene as to what's coming in. In my community, which I'll show some photos of later, these are mostly these blue pills called blue M30s. They have many different names on the street, but that's what these pills were seized as, and they're essentially just fentanyl or maybe some fentanyl analogs, but no one really knows what's in them for sure, unfortunately. And it's just been such a dangerous situation. Like Rita pointed out, sometimes it's our first experimenters that are having serious overdoses because these pills are, being made on the street. So I think at this point, we'll pivot as a group, Jen, Rita, and myself, really try to say, what can you do in your practice and what can we all do together to try to make this better? The first thing is we need to prescribe medication to get people off of opioids once they've developed an opiate use disorder or they've developed opiate dependency. And this is a plug to get your X waiver, which is the waiver on your DEA registration to be able to prescribe this drug, buprenorphine. Turns out France looked at this in the 80s. France had a heroin epidemic and they deregulated completely this drug, and overdose deaths dropped by over 80% nationally in the country. We're a little bit behind. We still do have a waiver that doctors have to get. Fortunately, it's really as simple as filling out a form, which we'll talk about in just a little bit. But if someone comes to you and says, I'm using opiates or I want to stop, as a healthcare practitioner, one of the single most life-saving things you can do is to get them off of whatever's on the street and onto buprenorphine specifically, because it is a very unique molecule. It is a mixed agonist antagonist at the opiate receptor, and it really blocks the effects of other opioids. So you really can't overdose on buprenorphine. It has a ceiling effect, and it's so potent in its binding at the opiate receptor that other opioids really don't have an effect. So once you get somebody on to a buprenorphine product like Suboxone and they relapse, they're really protected. And I'm just going to give some data briefly on how effective this is. I don't know about how many of you think about the number needed to treat in your practice, which is basically, it's a measure of the effect size of the intervention. How many patients do you need to treat to get an outcome? So for example, how many patients need to get an aspirin to prevent a heart attack? The number needed to treat. And just some brief notes here. The number needed to treat by giving people proton pump inhibitors like Protonix for an upper GI bleed to save a life, turns out it's infinity. There's no mortality benefit. The number needed to treat with aspirin to prevent a single heart attack is 2,000. The number needed to treat with aspirin to prevent a stroke is 3,000. And for my practice in the emergency department, people with cirrhosis who have a variceal bleed are so sick, antibiotics are actually extremely helpful. The number needed to treat is 22 to save a life and 4 to prevent infection. So that gives you kind of a reference or a way to understand the relative value. Well, it turns out starting people on buprenorphine when they have an opiate use disorder, the number needed to treat to save a life is 1.4 patients. So last night in the emergency department, I saw 2 people who needed buprenorphine. Statistically, I just saved one of their lives by starting them on buprenorphine, and you can too in your practice. Even if you think it's, I'm just in urgent care, what can I do? Somebody walks in the door and they've got a problem with opiates, getting them on to medication-assisted treatment is one of the most life-saving things you can do. The other thing that's really interesting is we've looked at what interventions prevent the supply of drugs from arriving into our community. This was a Rand Corporation study in 1999 that said, okay, let's look at the cocaine industry. What can we do to prevent cocaine from arriving into our community? And on the left, you have various interventions. On the bottom axis is how much drug does not arrive because of the intervention. So on top, you have DARE, then you have source control, which is spraying or destroying crops in another country. Interdiction is trying to, seize drugs at the border. You have changing, sentences for dealers. You have increasing domestic enforcement. You have all sorts of stuff. Look at the one that's most effective. Treatment of addiction is the most effective way to prevent the arrival of drugs into our community. When no one wants to buy these fake fentanyl tablets, we will see the supply go down. One thing that people often wonder is, well, can I break a pill in half? Would that protect me? And the answer is no. Unfortunately, because these are not pills being made by a pharmaceutical company, they're being made by people with labs at home. Interestingly, a lot of these people making these illicit pills are actually using very low-tech technology to be able to mix up their fentanyl and pill binders. So they're literally using stuff as simple as a magic bullet. And so you can see there next to the penny, that's again the potentially fatal dose of fentanyl, and it's not evenly mixed throughout the pill. It's like a chocolate chip cookie. There might be 10 chocolate chips on one side of the cookie and 3 on the other, but you really can't tell if that cookie has an outer coating, like a chocolate coating. And so you can see here, this is a picture of probably the most common counterfeit pill that contains fentanyl right now in the drug market. These are called M30s, or sometimes they're called Oxys or Percocet. You can't tell with that blue coating what's on the inside. And even if you break it open, fentanyl is white and the binder or cutting agent is white. So people really don't know what they're getting, and they can't tell where the fentanyl is. So even if you take even just a fragment of a tablet, you might be getting the part of the tablet that has all of the fentanyl. And some people say, I want to be smart. I'm going to test my pill for fentanyl. You can buy online what are called fentanyl test strips. That's a little reagent that you can shave off part of the pill and test it with this strip to see, is there fentanyl in the pill? And unfortunately, not all fentanyl analogs are detected. The ones that we give out in Monterey County test for about 200 analogs, but there may be more. And then additionally, how do you know that the little fragment that you shaved off even contains the fentanyl? So fentanyl test strips are great, but we have to understand their limitations. Rita, I think you were going to talk about naloxone.
Yes, thank you, Casey. So hopefully you guys are I'm sure you're all aware of Narcan. It's the overdose reversal medication, opioid overdose reversal medication. Comes in a nasal spray that you can get in these 2-packs, and they recently have just formulated a higher Cloxato, I believe is how you pronounce it, 8 milligram dose. I don't think that will be as readily available as this is through the state, how we can obtain it. But I think that is a valuable resource, because oftentimes we've heard with fentanyl being so potent that I've heard of as much as 4 nasal sprays it's taken to revive someone. But I just really encourage everyone to make sure that they have this, in their office, in their home, really anywhere, in their car. I like to refer to this medication as a fire extinguisher. You really hope you don't need it, but when you have it, you're grateful. And speaking from someone who just had a house fire last month, I am so grateful I had not only 1, but 2 fire extinguishers that really did save our house. So if you're ever in the event of encountering someone who's experiencing overdose, it would be, critical to have this resource that you could save someone's life. And I think sometimes I hear feedback that, oh, we don't have opioids in our house, or that, that's not an issue that we would encounter. And just one story stuck out to me is that was from a kind of a family that I worked with, was that experience. And then one time they had a friend come over, and a tramadol fell out of their pocket on the floor, and they had a toddler, and luckily their mother was paying, really good attention and saw the baby playing with this little white pill, and come to find out that it had fallen out of the friend's, so gosh forbid that the baby ingested that, they would have that resource there to save their child's life, although they didn't think they have the problem. So it's really just a great resource that we should all have. And it's great. And I think the next slide, Casey, if you can.
I'm just going to make one other point that sometimes people don't want to feel kind of stigmatized or singled out. And I usually say to people, hey, do you need some Narcan? You could save someone's life. And I think that's the way I look at it, is we collectively, by carrying Narcan, distributing Narcan, getting it to our patients, can respond. Once someone dies of an overdose, they can never have treatment.
Yeah, thank you. And a kind of an interesting statistic I've found on this is for every 32 people that are successfully revived or treated for OUD, for every 1 death. So that just shows how many lives this resource has saved. And I just want to leave you guys with this resource that you can obtain your own naloxone. You can go to your local pharmacy, see if you have a harm reduction in your county public health. I'm sure many of you work in agencies that qualify for this naloxone distribution project. So it's free from the state through DHCS funding. And so all you need to do is apply, and they have all the information there that you need. And they have the state physician can sign off on any orders if you don't have, but I'm sure all of you have resources to that. And I'm happy to help walk anyone through obtaining this application to have your own kits. And you know, you can order up to a couple hundred depending on what type of organization. So I hope that if you don't have it, that I encourage you to check this out after, and I'm happy to be a resource if needed.
Dr. Hastings, are you with us?
Yeah, and just adding that we recommend that you co-prescribe naloxone with every prescription of buprenorphine, or if you're prescribing another opioid. And the idea of having every household have Narcan is really a goal, certainly families with teens and small children. Yeah, so I'm queued up to talk about the sort of review what we've talked about, becoming ex-waivered, learning how to prescribe MAT, and co-prescribing with naloxone, and then learning from others is very rich. So we've created, gosh, when did we start, Rita? Maybe 2017 or something, an MAT advisory group. We have both at least quarterly meetings. We also offer a listserv where we share experiences, ask questions, and please email us at saferx@hipscc.org to join. That email is on the slide, but if you're listening, saferx@hipscc.org. We also encourage you to join your local Safe Prescribe, or it's called SafeRx in Santa Cruz. And I'll just, one more plug for our MAT advisory group. We pick topics that are timely. We've spent the last 2 meetings talking about how to prescribe in the setting of fentanyl, which the starting of buprenorphine can be a little bit different. So that's been extremely helpful. It's forming community. And we work closely with California Bridge, which provides incredible resources for learning. With the new ex-waiver easier access, where you don't have to do an 8-hour training if you're a physician or DO, and you don't have to do the 24-hour training if you're a physician assistant or nurse practitioner, we still encourage you to get training. There's so much to learn, and we've included other resources here. We really like the Provider Clinical Support System. PCSS now has fantastic webinars and another kind of learning community. In addition, UCLA has funding from the state opioid response programs to provide fantastic webinars and collaboration. In addition, Casey Grover, who's talking today, has a podcast that I highly recommend. Casey, I always learn from you. I'm deeply involved in this stuff, and it's always a pleasure to hear you. So I highly recommend Casey's podcast, and the link is here, anchor.fm/Casey-Grover. So next slide, I think. So yeah, the buprenorphine waiver notification became much easier, at least a year ago. And we have the link here on the slide for you to do that. At the Watsonville Hospital, some of the hospitalists, during the course of the meeting, filled out this form and became eligible to prescribe buprenorphine. It's very ironic to me that the waiver is still required. This is an extremely safe medicine, and it's just, I think, a perpetuation of the stigma around drug use that makes this still a requirement. I think the example that Casey gave in France, how with easy access to this medication, they really tackled their heroin issue very rapidly. And that was a long time ago. So next slide. Yeah, so we wanted to spend a few moments, and I know we want to stop soon to take questions, but harm reduction is an approach to care where you're really looking at reducing the negative impacts of behavior on a person's health. I'll give an example of harm reduction in my own practice. Historically, providers have done a urine tox screen to look for what we call drugs of abuse. And if someone saw cocaine or heroin or methamphetamine in the urine of a person who was taking buprenorphine, they would say, oh my gosh, you're not doing what you're supposed to, so I'm going to stop your buprenorphine. Well, actually, having that person taking buprenorphine is a support to them for preventing death, and you want to then work on other approaches to help them, either when they're ready or at that moment to look at the substances they're using. Another harm reduction approach would be meeting people where they're at. If someone is in a housing encampment, go to that encampment and meet with them and talk about the barriers to care. I think looking at stigma and increasing empathy is very, very powerful. I have now a colleague who shared that, she was on the streets, homeless, using heroin and pregnant, and she's now in a high-level position in our county. I think people can change. I'll just share one other story, which is early on when I was doing this work, it was on Overdose Awareness Day, and I was presenting about naloxone and medication-assisted treatment, and this woman stood up and said, I have been saved I think about 30 times. Please don't give up on me, meaning she'd taken naloxone 30 times. Please don't give up on me. That's my spiel. And I think other people, Rita or Casey, we're going to share each of your own examples.
Go ahead, Rita.
Yes, thank you, Jen. That was great. So I have kind of a different example. As I mentioned, we have a robust harm reduction coalition in our community. And I come from the background of pharmaceuticals. I have an immediate family member with a very severe substance use disorder. And when I started this in my current role, I really envisioned to help people decrease substance use and ultimately stop. And so we had a convening with our harm reduction partners. And when I said those words, when they came out of my mouth, they were kind of shocked and appalled. And we're like, whoa, that totally doesn't align with our ethos and what we envision. And I said, oh gosh, well, what do you guys, what is your goal for your coalition? And they said, oh, we just want to make drug use safe. We don't ever, if someone wants to reduce or stop, that's on their terms. But if someone wants to use every day or not, we want them to be just safe. And I was taken aback by that because of what I've seen my family go through. I'm like, gosh, if I can stop someone from becoming addicted, that's my ultimate goal. And it still is, and there still is their goal. And we were able to learn that there's, kind of a time and place for each of these, and we can hold space for one another. And I'm grateful that have their mission and our resource. And I think that they respect our goal and resources that we can provide. So I think it's just a good way to look at harm reduction is really a continuum of care. It's such a multifaceted kind of concept that doesn't just mean needles being handed out. And there's different perspectives. And so I think learning from each other about what hesitancies you have and having those kind of difficult, uncomfortable conversations can serve us well in our community to move forward and using this evidence-based practice in its most appropriate way. Thank you.
I think I've already said too much, so I think we'll go on to questions.
You never say too much, Casey. Sorry. It's all good.
Fantastic presentation, everybody. Oh my goodness. I've been sitting here listening to everything. So valuable for our members and everybody. And I do have some questions that have been submitted. So I think we can spend the next few minutes talking about that. And then also we will share this recording probably within the next few days to our whole email database, which is, I think, about 4,000 or something like that. And we will also post this recording in its entirety on the CALUCA YouTube page, which is also linked on our website. So hopefully this program will live on and serve a great purpose for our members and nationally as well. And then we'll also share the recording with you folks. So if you want to use that for whatever purpose, we're happy to accommodate that. So thank you everyone again. So I'm just going to throw out a couple questions and you all can discuss them. So the first question is, are there any typical physical or psychosocial traits common to ER for overdose? Sounds like a detective kind of a question.
I mean, as far as, kind of who are we seeing that's coming in with an overdose?
What do you look out for? What are providers and people? I mean, they've probably seen all this and not realize that they were seeing it at the time. So how would they know in advance or be better prepared the next time?
Yeah, I mean, I think there's four major risk factors for a substance use disorder. Certainly addiction, or an active addiction, which is, I'm thinking of, if I'm going to give someone a discharge prescription for Norco for pain, what do I need to worry about that would be a risk factor that Norco is going to be a problem? They have an addiction to another substance. They've had an addiction to that substance in the past. They have severe uncontrolled mental illness, or they have a significant family history of addiction. So when I kind of do my due diligence with people, and if I have to give them an opioid, I sit down and ask them those four questions. So if you're seeing someone and something doesn't seem right, sometimes just asking when you're taking your history, tell me, do you consume cigarettes? Have you ever had an addiction? What runs in your family? Has that ever come in, or has addiction ever run in your family? Those are things that I think might cue you that a person's at risk. I think Jen, Rita, and I all feel very strongly that there's so much stigma around addiction that it's in how you ask. And I think it's really important. I often have a proviso, like, I just want to let you know, this is a very stigmatized topic. I want to be very objective. I'm here to help you, but I can't help you unless I have all the data. So can you tell me, have you ever had a problem with this? Have you ever had an overdose? I mean, as far as what an overdose looks like when they come in, I think we all know that: unresponsive, poorly breathing, small pupils. And then obviously that would be a time that that you would want to administer naloxone or Narcan. And I know Dr. Pricey at Doctors on Duty, I believe they've actually had at least one reversal in their waiting room. So if any urgent care doesn't carry naloxone, they absolutely should. I don't know if I answered that question correctly. Go ahead, Jen.
I added, I put it in the chat. I think, all the things you're talking about are important, and in part because of the stigma and that people may not be willing to reveal necessarily. I think figuring out a universal screening in your setting is important. This is not a particular socioeconomic group. This is not a particular kind of person. This happens to anyone and everyone, all kinds of people. So finding screening that will help you and help people feel safe to share what's going on for them is really important. And I think, trauma-informed care, ACEs screening, all these kinds of things are very, very important to add to your urgent care setting. I just want to do a shout out. I meant to do it in my talk. Docs on Duty here in Santa Cruz and Monterey County has every single one of their medical providers is ex-waivered. That's the kind of action we need at this time. And I encourage every urgent care setting, every private practice, every community health center to have all their providers ex-waivered at this time. There's no reason not to do it. All the barriers have been taken away. Step up. This is really important. This is life-saving, and we're in the middle of another pandemic, in case you didn't make that clear. Thank you.
Yeah, that's awesome. I think you answered about three other questions. What role can urgent care providers play in the battle against drug misuse? You touched on all of that. Should patients being prescribed narcotics also be prescribed Narcan? You touched on that.
May I briefly comment on one of those questions you asked?
Sure.
So I didn't mean to interrupt. I'm so sorry, but I just wanted to give kudos where kudos is due. Doctors on Duty, Dr. Pricey is their medical director. And, as an emergency physician, usually the overdoses are going to come to me, right? If someone's getting Narcan, they're going to come to me. If somebody's using intravenous or someone's injecting drugs, a lot of times they don't feel like they can go anywhere else. They often come to me. What we've done in our county is, if the ER is the launch pad when it comes to getting someone off illicit opiates and onto a buprenorphine product, they need a landing pad. And Doctors on Duty has done that for us in our community. So literally correct me if I'm wrong, but they have a couple of slots a week where they can pick someone up who needs to be continued on their buprenorphine. And as we talked about, that is such a life-saving intervention. So in some ways, it's partner with your local emergency department. Most ERs are starting to do this. And sometimes that getting off opiates onto buprenorphine can be tough. We can help with that. And then once they're stable, the urgent care can continue. Or sometimes if somebody comes in and says, hey, I'm in withdrawal, can I just have a refill? That's an easy win there too.
Super. Yeah. Yeah. Hey,
I
Scott.
know you,
Great
I
job.
just want to say one more thing, which is collaborating with your local emergency room, encouraging them to become part of California Bridge so that they become a hub for referring out to your community, and then making sure your urgent care is a part of that network where patients can go to get ongoing care.
Awesome.
Sorry to interrupt.
Awesome. No, that's good. You guys, you covered just so many of these, they're all kind of related. Can medication-assisted treatment for SUD be done in the urgent care setting without disrupting operations? That one's way over my head, but anybody?
Yeah, I mean, I'll start. So I have asthma, and as such, I require medication for my asthma. And with buprenorphine, the only part that's hard is going from illicit opiates or even a prescribed opiate to the buprenorphine. And I'm going to leave that aside. But once a person is stable on their buprenorphine, it's just really as simple as medication refills. So let me give this as a context. So I work at our local syringe exchange. I work in a van next to a homeless encampment once a month. And people come in and I give them their refills. And then literally these encounters are about 3 minutes. Hey, how are you? You doing okay? Any side effects? Oh, okay. Maybe we'll adjust the dose a little bit. See you next month. If I can do it in a van next to a homeless encampment, it really can't be that hard. And in some ways, once they're stable, that's really where those kind of ongoing care visits can be so helpful. Kudos again to doctors on duty for bringing in mental health services in addition, because I think we all realize that addiction doesn't occur in isolation. So I think it may be that your urgent care has a telemedicine mental health service that they refer to, or here's our list of mental health providers. Let us know if you need help getting a referral. But it's really just about being sometimes nice to people and approachable so that they feel like they have a place where they can go and they're treated not badly. So often people tell me, doc, thanks for being nice. That one always breaks my heart.
Right. That's a great answer. So another question here, is it appropriate to screen all new patients coming to an urgent care for pain management with a tool for drug abuse like the DAST-10? Anybody?
I missed the beginning of the question. I'm sorry, I couldn't hear. It's a little.
Is it appropriate to screen all new patients coming to an urgent care for pain management with a tool for drug abuse like the DAST-10?
Yes, that's what I was saying in my comment, is that I think that universal screening is important and figuring out a tool that is good. And I think in my opinion, none of the tools are perfect. I think the DAST is certainly one of them. Casey, I don't know if you have thoughts on the best screening.
The answer really is the one that works. And so it may be that some people feel more comfortable with one tool or one's less time consuming, but do something. As I mentioned in my practice, let's say someone's got a broken ankle. If I go to give them an opiate, I ask them those 4 questions. Have you been addicted to opiates? Have you been addicted to something else? Do you have a severe mental health disorder? And does addiction run in your family? And that might be as simple as the screen is, but we've got to do something before we prescribe opiates. And sometimes even other medications too. People think stuff like gabapentin can be innocuous. I love gabapentin, but there's also gabapentin misuse. So I would agree with Dr. Hastings that yes, screen before you prescribe, even if it's just a provider-patient discussion.
Wonderful. Really, really great. So we have about 1 minute left. So I'm going to thank you all. Thank you, Dr. Grover. Thank you, Dr. Hastings. Thank you, Rita Hewitt, for being here today. Really, really, really appreciate this. This was such a valuable presentation for all of our members. And we will see you again next time. So thanks again. I'm going to just take over here and remind our viewers, here we go, that coming up next month is, or almost, look at that, the very end of April, is the UCA National Conference. And again, CALUCA will be hosting a meet and greet one of those days. So keep your eye on your inbox for details about that. And our next Urgent Care Town Hall, sponsored by Seth Yid, will be next month on Thursday, the 14th of April Wow,
And
sorry,
then I just see that there's a question about resources in Spanish, which is very important. And our materials that we create at the SafeRx are in English and in Spanish. We have an info sheet on Narcan, so we could probably read. I don't know if we can send that out. Our Narcan in English and Spanish. I think it's really. I mean, there are other languages that are important, but in our community, Spanish is probably the most common.
Fabulous. Thank you so much, Dr.
Thanks.
Hastings, for including that. Really appreciate it. All right. So thanks, everybody. That's it for today. You guys, everybody take care and stay safe. Thanks.